Schizophrenia is a chronic mental health disorder affecting up to 20 million people worldwide. It develops around late adolescence to early adulthood and has debilitating consequences on both patients and their loved ones. Symptoms are positive, negative, or cognitive based on the part of the brain they arise from and how they affect the neural circuitry. These include hallucinations, delusions, social withdrawal, learning deficits, and ADHD. In addition, various comorbidities exist with schizophrenia, such as bipolar depression, PTSD, and addiction. Schizophrenia is a polygenic disorder and primarily arises from deletions in chromosomes 6 and 22. While it is thought to be inheritable in predisposed families, many environmental factors also contribute to its onset. Substance abuse, obstetric complications, peri- and postnatal infections or inflammations are all major risk factors as well. As of now, we have no definite say on how schizophrenia works, and effective treatments are scarce.
That is until we consider the various hypotheses that describe the pathomechanism of schizophrenia. By understanding what's going wrong in the dopamine, serotonin, and glutamate transmission, we now have the know-how to design a great drug. First off, the dopamine hypothesis postulates that schizophrenia entails an excess of dopamine transmission in the mesolimbic system, while lack of occurs in the mesocortical system. Positive symptoms are thus attributed to the mesolimbic D2 receptor hyperstimulation, and the negative symptoms to the hypostimulation of the mesocortical D1 receptors. Specific dopamine receptor modulation in distinct brain regions can maintain balance between dopamine-induced excitation and inhibition. This equilibrium is crucial because increased dopamine antagonism induces Parkinson-like side effects, while an excess of dopamine agonism leads to hallucination and delusions. An excess of serotonin transmission in the anterior cingulate cortex and dorsolateral frontal lobe is also seen in schizophrenia. Hyperstimulation of serotonin receptors can in fact trigger downstream cellular signaling that promotes neuronal immunodegradation, which induces schizophrenia-like symptoms. From positron emission tomography imaging, we can further highlight this idea by pinpointing the exact area of cortical atrophy with abnormal serotonin transmission. With this information, we know that drugs need to inhibit serotonin receptors as well. Finally, a lack of glutamate transmission also explains certain facets of schizophrenia-like symptoms. AMPA and NMDA receptors are essential for brain plasticity, and schizophrenia-induced hypostimulation entails structural changes in the brain which result in positive, negative, and cognitive symptoms. Post-mortem studies show that there are reduced receptor densities and abnormal subunit compositions in the prefrontal cortex, thalamus, and temporal lobe. Therefore, glutamate receptors are a crucial consideration for drug selectivity. There is crosstalk between these three pathways, and one cannot hope to treat schizophrenia by simply targeting one of them, as they all modulate each other. These hypotheses point towards a grander problem linked to the genetics of schizophrenic patients, and failure to adhere to these principles lead to inoptimal drug designs.
Currently available antipsychotics fail to prevent the symptoms of schizophrenia in the long run and are accompanied by many side effects. These side effects include extrapyramidal effects such as akathisia, Parkinson-like symptoms and dystonia, neuroleptic malignant syndrome, muscle rigidity, and altered consciousness. Minor side effects also include drug-induced hypotension, weight gain, and sedation. I now present to you lumateperone, a newly FDA-approved drug for schizophrenia. This miracle drug acts on the many different pathways believed to be involved with the mechanism of the disorder. Lumateperone interacts with dopaminergic D2 receptors. These receptors are found on both pre- and postsynaptic neurons. It has agonistic effects on the presynaptic receptor and antagonistic effects on the postsynaptic one. Based on the nature of these receptors and the dopaminergic hypothesis, this drug is capable of downregulating the synthesis of dopamine and decreasing the effects of D2 inhibition on the postsynaptic neuron, allowing for proper dopaminergic stimulation. This novel drug interacts with the serotonergic systems in the brain. It is a potent antagonist at the 5-HT2A receptors, which prevents the overstimulation of these pathways that have been seen in schizophrenic models. It also has the ability to inhibit serotonin reuptake by SERTs, which prevents symptoms of depression related to decreased serotonin action in the brain. This compound can also interact with the glutamatergic systems in the brain. It can indirectly lead to the phosphorylation of glu-N2B and NMDA receptors. This results in an increase in the density of NMDA receptors at the synapse by preventing their internalization. This will strengthen the synapse and promote future plasticity. During phase 3 of clinical trials, lumateperone performed excellently, showing statistically significant efficacy for both positive and negative syndrome scale, as well as the clinical global impression severity of illness scores. It also did not show any worrying adverse drug effects, as cases of extrapyramidal effects were rare and the physical health of patients was not significantly affected.
But don't take our word for it. Here's Terry Crews with his testimonial.
Hey everybody! Don't
Don't use first and second generation antipsychotics. Use
lumateperone.